Welcome back to the Deep Dive. We're here to take your stack of source material, cut right through the noise, and deliver the insights you need, minus all that information overload.
And today we are tackling a really critical and deeply confusing issue in modern healthcare.
That's right, physician burnout. And we're zeroing in specifically on radiologists, those experts guiding so much of patient care from, behind the screen.
And the confusion you mentioned, it's palpable. As you, the listener, probably noticed when you looked at the research, the reported prevalence of burnout among radiologists is, well, it's an absolute statistical mess.
A mess is an understatement. I mean, you look across the studies, the systematic reviews, and the numbers range wildly from a low of, 5%?
5% in some studies?
All the way up to 85% in others. That's not just a standard deviation. That's a sign of a major, major problem in how we measure this.
Exactly. How can healthcare leaders address burnout if they don't know how big the fire is? These numbers give them completely different maps.
So that staggering variability, that difference between 5 and 85%, that's the central mystery we're trying to solve today.
That's our mission. We're going to evaluate exactly how burnout is being measured. And we're basing this on a huge systematic review of 57 studies covering over 11,000 radiologists from 1990 all the way to 2023.
Okay, so before we dissect the stats, let's just establish the ground rules. When we talk about burnout, we're not just talking about being stressed out from a long week. What's the official definition?
Right. It's officially categorized as an occupational phenomenon. It stems from chronic, unmanaged job-related stress.
And it has those 3 key dimensions.
It does. It's defined by a state of high emotional exhaustion, an increased sense of depersonalization, which, often comes out as cynicism or detachment, and then a reduced feeling of personal accomplishment.
And the stakes here are monumental. This isn't just about someone being unhappy in their job.
No, not at all. The downstream effects are systemic. Burnout is strongly associated with increased medical errors, tragically high rates of substance abuse, psychological distress. It impacts everyone.
And radiologists are right in the thick of it.
They are. The pooled burnout prevalence for radiologists is high. It's sitting at about 54%, which puts them right in line with other high-stress fields like general surgery and anesthesiology.
So let's dive into that measurement conundrum. We know the problem is serious. More than half of radiologists are struggling. But if I'm, say, a department head preparing for presentation and I need an accurate, defensible number, that 5 to 85% range is just unusable.
It's completely unusable, and that massive range is a direct result of measurement heterogeneity. We're talking about the differences in the instruments and, really crucially, the definitions that researchers are using.
So the test itself is part of the problem.
Exactly. The historical reference standard, which has dominated the research since it was created back in 1981, is the Maslach Burnout Inventory, or the MBI.
The MBI, right?
It's a 22-item survey designed to quantify those 3 dimensions we mentioned. It's the most common tool we saw in those 57 studies, but it is also the major source of this measurement crisis.
But if it's the gold standard, what makes it so unreliable?
Well, 2 things. First, just its variation. Some studies use the full 22-item version. Others use a 12-item or even a 7-item version.
Okay.
But second, and this is the fundamental problem, is the arbitrary nature of its cutoff scores. The original scores that determine if you are burned out or not, they were defined arbitrarily.
Arbitrarily. What does that mean in scientific terms?
It means the scores were set based on a simple tercile split. They just took a convenient sample of workers, divided them into 3 equal groups, high, medium, and low, and called it a day.
Wow.
They were not defined through rigorous clinical observation or correlated with actual distress that, impedes a person's ability to function.
So let me get this straight. They established a statistical cutoff on a general sample of employees and then tried to apply that to physicians who are facing chronic, severe life or death stress.
Precisely. And that approach just significantly limits the MBI's validity when you try to use it as a binary yes or no diagnostic tool. It was meant to measure intensity, not diagnose a condition.
That is a staggering flaw for a tool that's been used for 40 years.
Right.
So is there a rescue boat in this sea of statistical confusion? What numbers should you, the listener, actually trust?
Absolutely. When we look past the MBI's flaws and we focus on instruments that were actually designed for physicians and validated for clinical relevance, the picture gets much, much tighter.
Okay, which ones are we talking about?
The Stanford Professional Fulfillment Index, or
Right.
PFI, that one yielded a pooled burnout prevalence of 39%. And then there's the validated single-item instrument, which just asks, Do you feel burned out because of your work?
Simple enough.
And that yielded a prevalence of 34%.
Okay, so 34 to 39%. That's a tight defensible range. That feels like a number you can actually work with.
That's the essential takeaway. It suggests the actual likely prevalence is about 1 in 3, maybe a little higher. The PFI and that single lighting tool are shorter, they're non-proprietary, and they showed far less variation. They really are the current best practice for a quick, uniform assessment.
So we've solved the problem of the wildly variable percentage, and we've established a reliable number in the mid to high 30s. But relying on a single binary number, even a reliable one, it still feels like we're missing the crucial diagnostic nuance.
It is. The sources really insist that burnout is more than binary.
Right.
And this is where the MBI, despite its flaws as a binary tool, actually becomes useful again. Its strength is in those 3 distinct dimensions it measures. Let me show you how just changing the definition of burnout using the MBI's own subscales creates a statistical earthquake.
Okay, lay out those definitional shifts for us.
So, if researchers use the strictest definition, requiring a radiologist to test positive on all 3 subcategories, high emotional exhaustion, high depersonalization, and low personal accomplishment, the pooled prevalence across studies plummets to just 19%.
19. So less than 1 in 5 fit that profile of being completely, for lack of a better word, engulfed.
Correct. But if the definition is softened to requiring a positive result in at least 2 of those subcategories, the prevalence more than doubles to 42%.
42, okay.
And if they only require a positive result in at least 1 subcategory, the prevalence skyrockets to 57%.
Wow, so we just jumped from 19% all the way to 57% based entirely on semantics and research methodology.
Exactly. And that difference is statistically significant. It tells us those definitions are tapping into fundamentally different experiences of stress. We can't treat the organization if we only know that one binary number.
We need the subscale snapshot.
We need the subscale snapshot to see where the pressure is actually hitting. And among radiologists, the pooled prevalence showed high emotional exhaustion was at 54%. High depersonalization, that cynicism and detachment, was 52%.
But the low personal accomplishment was quite a bit lower.
Right, that was at 36%. So the fact that over half are struggling with severe emotional exhaustion and cynicism, that shows where the chronic stress is hitting hardest. It's not necessarily that they feel incompetent, it's that the work is just draining them and making them indifferent.
And this isn't a static problem, is it?
No, and this is highly concerning. The longitudinal trend we pulled from the review shows that between 1996 and 2023, there's been a statistically significant increase in the prevalence of high emotional exhaustion. It's rising 1.2 percentage points per year.
Per year.
And high depersonalization is rising 1.5 percentage points per year. The core stress factors are actually accelerating.
So let's pivot and ask, what is it about the specific demanding context of radiology that's driving these persistently high and increasing rates of exhaustion and detachment?
Well, the sources identify several powerful systems-level pressures. The first group relates directly to workload, and that drives the emotional exhaustion. We're seeing just massive increases in imaging volumes,
More scans?
way more scans, and higher utilization of really complex cross-sectional imaging, CTs, MRIs. Radiologists have to read an increasing number of increasingly complex scans per shift just to keep up.
That's that feeling of constantly running on a treadmill that's just speeding up.
Yeah.
It's the cognitive load, the time pressure, that's the exhaustion.
Exactly. And the second major factor speaks directly to that high depersonalization, the cynicism. And this relates to changes in practice patterns.
Like what?
The wide adoption of electronic medical records, or EMRs, and the expansion of remote work policies, especially since the pandemic, it's led to increased social isolation.
That is so jarring. The technology and flexibility that was meant to improve their lives, like working from home, is actually feeding the cynicism because it robs them of community.
It robs them of community and that connection to the larger purpose. You start to feel like a cog in a machine, disconnected from the actual patient. That disconnection is just central to depersonalization.
And the subgroup analysis had some interesting findings about what didn't matter. Yeah. Right? Challenging some common assumptions.
It did. Give us those. Despite the intense public focus on the pandemic's impact, there was no statistically significant difference in overall burnout prevalence in studies done before versus after COVID-19.
So COVID didn't create the burnout crisis in radiology. It was more like an accelerant on an already existing structural fire.
That seems to be the case. And what about differences within the workforce? Surprisingly, no statistically significant differences were found between trainees and faculty. Residents and attending physicians are suffering at comparable rates.
Wow. And between men and women.
Also, no statistically significant differences in the overall prevalence. The sources suggest that experiences vary far more dramatically because of site-specific factors, the culture of a specific hospital or practice, which isn't captured in these broad demographic buckets.
This all leads to one conclusion then. If the problem is chronic, it's multidimensional, it's systemic. We cannot rely on flawed binary metrics or just generic calls for more resilience from doctors.
Exactly. We need an actionable map for solutions. And for that, we turn back to the strengths of the MBI subscales, specifically using the burnout profiles that were developed by Maslach and later.
Okay.
This framework transforms all that complex data into 4 clear organizational categories that can help leaders prioritize resources and target their interventions much more effectively.
So let's break down those 4 profiles. There are essentially 4 different diagnostic labels for the organization.
Right. The ideal state is the engaged profile. Low exhaustion, low depersonalization, high personal accomplishment. That's the goal.
The healthy state.
The healthy state. But then we move to the profiles that need intervention. The first is overextended, which is characterized by high emotional exhaustion only. This person is just working too hard. They're constantly drained.
So if your staff is primarily overextended, you know your intervention needs to be about efficiency and workload reduction. You need more staff or shorter shifts, or you need to invest heavily in AI or automation.
Precisely. The second profile is disengaged. This one shows high depersonalization only. They aren't necessarily physically exhausted, but they're cynical, they're detached, they lack motivation.
And the intervention there is fundamentally different.
Completely different.
You can see why. If someone is overextended, you give them a day off and maybe they feel better. But if someone is disengaged, they feel isolated and cynical. Giving them a day off won't fix that underlying problem. It won't fix the meaning or control issue.
That is the heart of the distinction. For the disengaged, you need team-building initiatives, better communication, and systemic efforts to increase their autonomy and their community involvement. It's about fighting the isolation.
And the last category.
The most severe, the burned out profile. That's characterized by all 3. High EE, high DP, and low PA.
The crucial realization here is that you can't treat all 3 of these profiles with a single solution, like a wellness app.
No. The research emphatically proves that the response has to be organization-directed, systems-level solutions. The problem isn't the physician's inability to cope. It's the organization's structure that's creating the disease.
So what are some of those tangible, systems-level interventions?
The sources list several that warrant more research. Serious workflow changes, scheduling modifications like creating shorter or overlapping coverage shifts, and rigorous, intentional efforts to foster community and build better teams. These are operational solutions, not psychological ones.
This has been an absolutely essential deep dive. You, the listener, you now understand why those burnout statistics have been so chaotic. It's the faulty instrument definitions, especially the MBI's arbitrary cutoffs.
And you now know where to look for reliable prevalence estimates. The Stanford PFI, or that single item measure, which places the likely prevalence around 34 to 39%.
And crucially, you understand that to truly intervene, you have to use those MBI subscale profiles to figure out if the primary problem is exhaustion or if it's cynicism.
Because the high and increasing prevalence of emotional exhaustion and depersonalization indicates that chronic systems-level stress is the driving force in radiology. The organization is failing to provide a sustainable work environment.
And that brings us to the final thought.
Right. If stress is trending upward, then the essential outstanding issue is not simply preventing the bad things, like reducing stress or blocking burnout, but actively understanding what workplace factors create fulfillment within the profession.
That's the difference between merely stopping a leak and actually building a sustainable structure.
Exactly. We should encourage you, the listener, to consider what organizational changes your own workplace context needs right now to foster engagement and professional fulfillment, not just what it needs to prevent the next wave of burnout.
That shift in focus from deficit to growth, that might just be the key.
It might be. It's the critical next step.
A truly necessary, provocative conclusion. Thank you for guiding us through this deep dive.